Okay, so this is another 41 years old female who presented in October 2020 with chest pain that occurred while she's having severe migraine. She's going through divorce and very stressful times. Her past medical history is significant for hypertension and recurrent migraine headaches. She takes L-triptan and spironolactone for her headaches. Her blood pressure on admission was high at 147 over 79, and her heart rate was 72. She had high sensitive troponin of 0 that increased to 2000 in 10 hours. This is her presenting EKG. She was chest pain free at that time. That showed just normal sinus rhythm and nothing specific or nothing suggestive of ischemia. This is 2 hours later while she's having actual chest pain. And as you can see, you can look at the lateral leads here, V5 and V6, and compare them to previous. And there is hint of AC segment elevations with flip T waves, these are ischemic findings. So due to elevated troponins and the patient chest pain and EKG abnormalities, she ended up with an echo, and the echo showed normal biventricular function. And I don't know if you guys noticed the wall motion abnormalities or not, but I'll direct your attention to this anterolateral wall here, mid to distal segments, that's hypokinetic. So this is the contrast echo. Again, this anterior, it's not the best images that we have, but as you can tell that the anterolateral wall here is akinetic as well. So patient ended up with a left heart catheterization after presumed diagnosis of acute coronary syndrome. So her cath was normal. It didn't show anything unusual in her LCX, and that was what we thought is the culprit. Patient ended up with a diagnosis of MINOCA, which is myocardial infarction with non-obstructive CAD. And then we ended up with, this is other views of the RCA. We ended up with a cardiac MRI. So 2-chamber, 3-chamber, and a 4-chamber view. And I'll direct your attention again to the anterolateral wall, mid to distal segment with hypo to here actually looks akinetic, not hypokinetic anymore. This is the 4-chamber view, and this is the late GAD enhancement pictures. As you can see from the mid all the way distal anterolateral wall is all late GAD enhancement, which is in acute settings can be edema, obviously, but it also can be scar in subacute or chronic settings. Short axis view, basal to the distal walls, and it shows us that the anterolateral wall from the mid to distal, it has this akinetic segments, and late GAD enhancement shows us as well that it's a transmural with this small island of darkness, which is MVO, severe microvascular obstruction. So the final diagnosis for this woman was vasospastic angina that was associated with migraine. We ended up having patient adjust some of her medications and to help her migraine while not causing vasospasm. Patient actually felt better in some of these medication adjustments. We started her on anti-androgens as well, like calcium channel blocker, and patient had recurrence of symptoms only one time within 6 months follow-up, and it was associated with a migraine. But since then, the following 6 months, patient did not have any episodes, and her EF only slightly improved, but the wall motion abnormality remained the same a year after her presentation. Thank you for listening, and I'm open for questions.